Yes, hi. This case is a 83-year-old gentleman, and he has Alzheimer's. He was okay at the office, and his first eye went really well. The second eye, he was a little bit more agitated and moved a lot during the procedure. Probably the timing of the surgery. This was done later in the day, and they do better when they're done early in the morning. So you'll see sudden moves during the procedure, and he kept on putting his legs up and moving his head every once in a while in a sudden fashion, and the nurse has to just calm him down and until we're done with this procedure. Giving retrobulbar anesthesia in this case won't make the difference because they still can move the whole head. So it's not just moving the eye, it's moving the whole head is the problem. So if you find an Alzheimer's patient and you're not sure if he's gonna do on local, just go to and do it under general. Okay, retrobulbar would not do the trick because of the head movements. You can see that he's looking at the light, but every once in a while there is a big movement because of the movement of the head. Here you have to be quick and swift to be able to finish the surgery soon, and get one of the nurses to maybe hold his hand, talk to him until we're done with the surgery. But we have a very severe shortage of anesthesia in our hospital, so I don't have an anesthetist most of the time. Maybe I get 1 day a year with an anesthetist, so we do most of the cases under local. So you can see sudden movements, and really you have to be just watchful of the coming movement and just move with it until it's surgery's done. When a patient starts to have Alzheimer's and he has a small cataract, I think it's a good idea to do it while it's still early, because when it's early in the stages of the disease, you can still do it under local. If you wait until it's more advanced, you're probably gonna need to put them under general. So that's the second advice about Alzheimer's patients. If you see a cataract in an early Alzheimer, you better remove it when it's early, and you can do it under local, topical, rather than waiting until it gets more advanced. These are one of the cases that you should do the cataract early, like in the cases of pseudoexfoliation, the same. You can see big movements happening because he's actually moving, he's actually putting his legs in the air. I asked him, there's no pain, but he's just agitated. We usually offer the patients to have like an Ativan, 1 or 2 milligrams of Ativan before the surgery, but sometimes they don't take it, just choose not to take it. Okay, so I'm done with the phaco. Use the J cannula again. You have to be very extra careful and try to stabilize the whole head by putting your the palms of your hands on the head, so that the movement of the head is translated into your hands at the same time, so the whole your head and your palms and hands all move together. If you start moving, again, better just put them to sleep and do the surgery that way, but it's not always available, so you have to do what you have to do. So done with the J cannula, injected Helon, and I'll just implant the lens. My routine lens is ZA 9003. It's the Technis acrylic wave-fronted guided lens. It's a good lens. It moves again. The lens is in. That's good. I'm just gonna do a little bit of IA. At this stage, we have 2 nurses helping stabilize the patients. moving more and more and more. You can see that his pupil is not that great, partially mid-sized pupil. Can't remember if it was on Flomax or not, but it seems to be a smallish pupil. Rate the wound. There's a small piece of cortical material I have to remove and go in to remove the IA again. Generally went okay. Again, the advice is just if you're in doubt about Alzheimer's patients, just put him to sleep. If it's an advanced early ones, remove the cataract early to avoid this situation. Thank you very much for watching.